Hey guys, welcome to part 2 of non-invasive ventilation for Lab 2160. This will be more of a theory and settings module, or video, excuse me. We will be covering non-invasive ventilation as a module in 2320 also, and further in lab. This is a very common and very much used part of our profession. So I'm gonna try to make this as detailed, but not so detailed we're overwhelmed video for you guys. We're gonna start by, say you are called to a room to set up a Bipap for a patient that is having respiratory distress. I come in, I grab all the supplies I need, which includes my sterile water for inhalation, my Bipap, make sure I have a clean circuit that's ready to go and is set up properly, and then an appropriate sized mask for a patient. Most patients, in respiratory distress, you'll use a full face mask, which is like the one we have attached here, which covers the nose and the mouth. But there are other types of masks involved, and we can get into that later, such as over the nose, in the nose, or over the entire face. If a patient is in respiratory distress, use either a full face mask, which is like this, that goes over the nose and the mouth, or what's called a total mask, which goes over the entire face. It may also be referred to as a scuba mask, because the nasal mask and the nasal prongs will cause too much of a leak to support ventilation. But those can be used for sleep apnea situations. Very appropriate for those. So I have my circuit, my mask, everything ready to go. I'll come and I will get my equipment. I will plug the oxygen, where's my camera? Into the oxygen port, you just push. And my electrical into the red circuit. The reason we do the red circuit is because this is hooked up to a backup generator that will give continuous energy, or electricity, sorry. It will give continuous electricity off the backup generator without any pause, so that all of our respiratory equipment will get top priority for any electrical situations, such as if the power goes out, which I have had happen. I've had the power go out and backup generators happen, and I've been very glad for these red outlets. Sorry, lots of moving. So now that our Bipap is set up, we're going to press, we can see that our battery is charging here with the yellow button, and that we are in a standby situation because we are yellow, but we are plugged in. So I'll press the on button. I'll place this into standby. So let's talk about the different features on the Bipap. We're going to start with the modes button. So with the modes button, we will be able to see, let me see if I can make this a little easier for you guys to see. Okay. There are different settings we can use. We have CPAP Mode, which stands for Continuous Positive Airway Pressure, and that is one positive continuous pressure. This can be used for situations such as oxygenation, where we have a patient with overwhelming atelectasis but ventilation is appropriate, where we just need to give pressure to open up the alveoli, or most commonly it is used for sleep apnea situations to stent open the upper airway. Over it will say ST, batch or batch ST. That stands for spontaneous timed, which is the actual non-invasive Bipap mode. So if you see ST, that stands for spontaneous time. And then the other one we're going to look at is PCV. That stands for pressure control ventilation. These machines can be used as a ventilator if they need to. This is something that a lot of Arties are talking about right now with ventilators. So this can be used as a ventilator, but most of the time you're either going to use CPAP or batched ST mode. We are currently in standby, so which is this button over here, which is the machine is working and it's functioning, but we are not attached to a patient, and so we don't want it to be alarming and freaking out. Up here, so there are a couple ways to take it out of standby. You can either have a patient put it on and it will trigger it, or you can press this button right here that says restart ST mode. Along here will be alarm messages and different things that might need to be addressed with the Bipap. So let's show you. So CPAP mode. We set up the pressure we want. So we can go up in pressure. So 10 is what's called therapeutic PEEP. If you have a pressure of 10 or higher, it's considered therapeutic. You can do a ramp, which over here you can see as you change your ramp, it is how long it takes to reach that set pressure. So it can ramp up. Most patients don't love a ramp, but it is there if you need to go from a lower pressure to a higher pressure. And then similar with C-Flex, it's how sensitive it is for the patient to take a breath, or how difficult or easy. Most patients find a C-Flex of 2 comfortable. So 2 or 3, I normally don't take it off of a C-Flex of 2. And then over here is your FiO2. This is the percentage of oxygen we're giving our patient. We breathe room air at 21%, with 100% being the max, 100% oxygen. And you can dial in how much FiO2 you want to give. This might be a situation you use this dial. This is a touch dial, so you can either dial up, and it will change it, and you can select, or dial down. Okay. This is what we're going to spend quite a bit of time on, and I'll show you all the waveforms and everything we can do. So these first two, this is your IPAP or your PIP is what you'll hear. This one's your EPAP. We're going to spend a little bit of time on this. EPAP, CPAP, and PEEP are all the same theory. This is pressure applied to exhalation in order to keep the lungs inflated. Okay? So I'm going to just say that again because it's a very important concept with both non-invasive and mechanical ventilation. EPAP, CPAP, and PEEP are all pressure provided at the end of exhalation to maintain the lungs and airways open. IPAP, inspiratory positive airway pressure. Oh, sorry, I forgot to say EPAP is expiratory positive airway pressure. IPAP, inspiratory positive airway pressure, and PIP, peak inspiratory pressure, are also the same. IPAP and PIP. This is the pressure needed to reach the top of inhalation or to support inhalation. So I like to think IPAP and PIP assist ventilation. EPAP and CPAP assist oxygenation. So if you're looking at your patient and they're having an issue with breathing and CO2 and ventilation, I would change the IPAP. If I had a patient struggling with oxygenation, I would change the EPAP or the CPAP to help open up those airways to improve oxygenation. The difference between the two, what you'll commonly hear it called, is the change in pressure or the delta P. So, it's a little easier to see. So with the BiPAP, it doesn't automatically change. So if you have a patient that is having oxygenation issues, if you increase your EPAP by 2, in order to keep that same window of ventilation, we would increase our inspiratory pressure by 2. And I'm going to go over that again after we go over all these settings. This is your rate. Depending on what's going on with your patient will depend on where you set your rate. If a patient is on non-invasive ventilation, they need to be breathing spontaneously on their own. They shouldn't have to rely on a non-invasive mode of ventilation to fully support their ventilation. So I typically will put their rate around somewhere between 10 and 20. I typically like it on the lower end because I want the patient to do most of the breathing on their own. I time, right here, that's the time it goes from end of exhalation to peak inhalation. So how long it takes to take that breath in. Most patients will find an I time of 1 second most comfortable. Let's say I have a patient who is having oxygenation issues. I will give a longer I time. This allows longer time with inhalation with a little bit shorter time of exhalation, which allows for improved gas exchange. The two things that are most helpful with gas exchange are pressure and surface area. So with a longer I time, we get a longer surface area with a higher pressure for a longer time. But inversely, let's say we have a patient with CO2 issues. This patient would want a shorter inspiratory time to allow for a longer expiratory time to blow off that CO2. I know this concept is a little confusing. We're going to go over it again in 320 and also when we talk about different modes of ventilation. So just put it in your brain right now and know we're going to return back to this concept. Rise is how aggressively I deliver each individual breath. So if I have a shorter rise, it's going to deliver it faster and more aggressively. Where if I have a longer rise, it will take longer to deliver that breath. So you might be thinking, I time and rise are pretty similar. What's the difference? I time is an actual timed time we do inspiratory. We take that breath in. Rise is, this isn't the best word, how aggressive. Or it's the flow we use to deliver. The analogy I like to use is, so you guys are going to hear me talk about Artie a lot in this class. She's my dog. When I take Artie in the car and she's seatbelted in, she loves sticking her head out the window. So let's just say she sticks her head out the window for 1 second, which is our I time. But she's going to feel it differently if I'm going 15 miles an hour down the road or if I'm going 40 miles an hour down the road. That's how they relate. So she's going to stick her head out the window for the same amount of time, whether it be 1 second, second and a half, 0.78 seconds. But the rise is how much flow we are using to deliver that breath. So again, that's the how fast I'm going in the car with her. This is the ramp. Some facilities have, similar to CPAP, that's how long it takes to reach those set pressures. But if I have a patient in respiratory distress, I'm just going to want that pressure immediately. And then finally over here, we have FiO2, which is our percentage of inspired oxygen. A few other things before I turn it on and show you how the different setting changes work. We have our alarm settings, which has our high rate and our low rate, our high tidal volume and our low tidal volume, our high inspiratory pressure, our low inspiratory pressure, our low minute volume, and our low inspiratory time. So basically disconnection. This is how long they can be disconnected for before the machine freaks out. Menu, you can change all the different things on here. So when we get to class, hopefully we get in the lab, we can show you everything. So we have brightness, loudness. The most important one you guys will look at is mask or port. And depending on what mask you get, so this one's a number 1. It will tell you on the mask what type of mask it is. So I'll say I'm using a 1 non-invasive mask, except that I have the port hooked up to my whisper valve. And that's all it needs to know in order to work appropriately. Okay, so let's put in our settings that we want. Oh, hi sticker. Okay. So once you put in your settings, so right now I have an inspiratory pressure of 10, an expiratory pressure of 5, so our PIP is 10 and our CPAP is 5. That's the continuous pressure we won't go below, and then is 5, and then the inspiratory pressure will be 5. So that change in pressure, or that delta P, you might even hear it called a pressure support, is 5, because that's the difference between the IPAP and the EPAP. We'll give a rate of 10, have 40% oxygen, then I time of 1, a rise of 2. So after that, we press restart, ST mode. And then up along here, you will either see inhale, exhale, or timed. Timed is when the... Oh, you guys are going to hear that a lot. I'm sorry. Timed is when the machine delivers the breath, delivers that IPAP. Exhale is during exhalation, and inhalation is when the patient takes a breath. Up here you'll see the rate, which right now we're breathing 10. The tidal volume, which you can adjust, and we're going to go over calculations to see how big of a volume you're delivering to your patient. So if you were giving too large a volume, you would go down on your inspiratory pressure. If you're giving too small a volume, you would go up, because it will change it. This is your minute ventilation. This is the amount you're breathing in 1 minute. So this is much lower. Sorry, I don't have it attached to a patient. So this would be rate times tidal volume, and your tidal volume will be in milliliters. This is your PIP, your peak inspiratory pressure. This is your leak. Most of the time you want your leak less than 30, not just going into the air like right now. This is the percent the patient is triggering. And then this is the percent of I time to total rate. So as you can see, I have all these alarms on the side because I don't have it connected to anything. Another button that is with some of the newer software that I love is this 100% FiO2 button. We have our high priority alarms. Which you can see here. And then to talk a little bit more about concepts, I'm going to try to find a whiteboard to show you guys, but I wanted you to get familiar with the screen as of right now. And then to put it in standby, you can either press the standby button. After it's disconnected, it will enter standby. And then you can hold this button down. And then it'll say ventilator shutdown or cancel. We're going to press ventilator shutdown. Okay, so I know you guys are going to have lots of questions. This is kind of a new concept. It feels kind of uncomfortable in your brain when you first start talking about ventilation. There's a lot of different words being thrown around, IPAP, EPAP, rate, rise, all this stuff. It kind of sounds a little bit crazy, but we're going to break it down. Make sure to ask us lots of questions. Both Heidi and I are available for questions, emails. You can text me or call me if you're struggling with something. And we're just going to keep coming back to this on how to use non-invasive ventilation. So please get in contact, and then we're also going to talk about it in 2320. So we're not done with this just yet. In fact, this is a huge part of our job as respiratory therapists. So study hard and keep us in the loop, and we'll see you in a bit.